Next speaker will talk about strain imaging and cardiac practice today. There are two types of teachers. One who makes simple things very complicated. And second, very complicated things are made easy. I will put Dr. J.C. Mohan on the second category and let him continue his talk. Thank you very much, Dr. J.C. Mohan.
Thank you, chairpersons. In last 30 years, two changes have taken place. We have moved from chamber analysis to myocardial analysis. Chamber analysis was so elegantly shown by Dr. Allegation, and we have moved from 2D to 3D, which was again shown so elegantly by Dr. Allegation. The heart actually has certain rule-based coexistence of complexity and simplicity, discreteness and continuity, unity and diversity, consent and dissent. And we need to understand the architecture, to understand the deformation the heart undergoes, to understand the function and pathogenesis of various disease processes. The first principle to keep in mind is that whether you are talking of ventricles or atria, the heart is non-Newtonian, almost synchronous, bidirectional generator of force, depending upon the mass of myocardium. Obviously, the atria will generate less force, and ventricles will generate more force. And amongst ventricles, left ventricle will generate more force than the right ventricle. The other thing which is so easy to understand, number two, is cavity change, or the chamber undergoing a volume change is subsequent to myocardial force. The prime mover is myocardial force, but as I said, the myocardium or heart is a force generator. So we are now trying to move away from chamber analysis to myocardial analysis, which means we want cavity-based measurements, but we also want myocardial-based measurements, those being more reproducible, more robust, with the incremental value in diagnosis and prognosis. And of course, the present era combines the two, the cavity-based measurements and myocardial-based measurements. So having said that, myocardium follows Hooke's law to some extent. What is Hooke's law? Hooke's law says force developed by the myocardium is linked to deformation or strain produced by it by a factor which is called elasticity. More elastic an object is, more it will be deformed by a given force. So there are two distinct domains change in elasticity. Elasticity of myocardium can change because myocytes undergo a change. These can hypertrophy, they can develop macromolecules which make these myocytes inflexible, or extracellular matrix can develop. Both these domains will change elasticity of myocardium, and hence will change the relationship between force and strain. So here is the relationship between force and strain by Hooke's law. But the balancing thing is elasticity. How is elasticity affected? Elasticity can be affected by myofiber architecture, as you see in hypertrophic cardiomyopathy, fibrosis, edema, inflammation, ischemia, and of course reduced tensile strength as the muscle undergoes a change. So eventually, if the force goes down, the strain would go down. But if the force remains same, strain can still go down because the elasticity is less. So you would understand this whole basis of strain imaging. So strain or deformation, nothing but alteration in geometry with application of force. In other words, when a piece of myocardium, piece of this meat undergoes shortening, lengthening, or thickening, you call it strain or deformation. Major vectors of strain are longitudinal, radial, tangential, and rotational. And premise of strain, as I said, is why are we thinking of myocardial analysis or quantification more than chamber analysis? Because the premise of strain is some vectors of strain run ahead of change in displacement. They run ahead of change of volume. And they are differential with regard to phases of cardiac cycle. So they provide incremental information, both with regard to the function and also the physiology of that function. The other premise of strain presumed function is that strain would be more sensitive, more objective, more robust quantification of cardiac function, and it would be aligned along internal coordinate systems. But it would have several caveats. So what is the appropriateness of strain imaging in cardiovascular disease? The appropriateness criteria of 2019 suggest strain may be used in routine practice. With the points given 6, remember the transthoracic and stress, transthoracic echo has a 0.9, which means it is appropriate. Stress echo, it is appropriate, but strain imaging may be appropriate. Remember, that is 2019, just 3 years back. So it tells you where we stand as of today. So what do we do with strain imaging in clinical practice? Diagnosis, etiology, prognosis, treatment, follow-up, device management, need for endomyocardial biopsy, reverse remodeling, so on and so forth. What kind of strains do we measure? Essentially 3 types: longitudinal strain, radial strain, circumferential strain, and of course, the longitudinal deformation or strain is largely based upon subendocardial fibers, but that contributes only 1/3 to the ejection fraction. Circumferential fibers or circumferential and mid-wall fibers contribute 2/3 to the ejection fraction. So when you talk about circumferential strain, you essentially are talking about ejection fraction. But when you're talking of longitudinal fiber strain, you are talking of something more than the ejection fraction. How do we assess deformation or strain? Tissue velocity imaging, we have given up because of angle dependency. Acoustic speckle tracking, whether in 2D or 3D, and examples of which were shown to you by Dr. Allegason with regard to 3D strain. Velocity vector imaging, which is slightly different from acoustic speckle tracking, MRI and CT. The normal values by the 3D echo box, longitudinal strain is in the ballpark about -20%, circumferential strain -25%, radial strain 40%, and twisted rotation about 10%. Okay. So having known that, what do we understand with regard to strain in 2022? All strain vectors help us to understand cardiac mechanics in health and disease. There is no doubt about it. We also understand compensatory mechanisms in subclinical disease better with strain. However, point number 3, circumferential and radial strains don't provide incremental clinical utility. You may use them, you may be happy mentioning our circumferential strain and radial strain. These do not provide incremental clinical utility. Longitudinal strain is the only one which provides incremental clinical utility and is there for prime time use because of its early involvement in disease process, its robustness, reproducibility, standardization, and of course incremental value. Regional strain is not ready for prime time use. Reason absolute test retest differences are much larger in regional strain. Wish we could use regional strain, but it's not ready for prime time use. Why GLS and why not global circumferential strain? Dr. Burkula did mention that maybe GCS might find more utility in cardio-oncology or oncocardiology, but as we stand today, ejection fraction and GCS are one and the same thing, practically. However, the relationship of ejection fraction and GLS is less tenuous. Right ventricle strain has been validated with regard to right ventricle free wall and right ventricle function in right ventricle focus view, and this is an excellent way of assessing right ventricle function. In a similar way, as Dr. Anirudh Dey took you through the left atrial strain, it has been validated for left atrial function, mostly the reservoir strain. So currently, there is a prime time utility for peak atrial left atrial reservoir strain and not for conduit function and contractile function. So where can we use strain imaging? This is a whole list. You can go through that. But of course, the LV function, subclinical and clinical, RV function, LA strain, predicting filling pressure, understanding heart failure phenotypes, physiological versus pathological hypertrophy, understanding muscle mechanics, dyssynchrony, viability, reverse remodeling, predicting fibrosis, monitoring chemotherapy, which Dr. Burkule took you through very elegantly, the more than 15% change telling you something is getting wrong with this heart because of drugs. And of course, monitoring heart transplants, cardiovascular health of population. There is a correlation between GLS and left ventricular ejection fraction, but there is a wide coefficient of, there is a wide confidence intervals, but nevertheless it is there. There is a definite relationship with the right ventricle longitudinal strain and right ventricular ejection fraction. Again, wide confidence intervals. 2D strain would have better traction if regional strain was reproducible. Unfortunately, regional strain is not reproducible. Although we keep showing cases where regional strain is of use, if regional strain was that much reproducible, we would have been using in stress echocardiography routinely. Here is an example actually of a patient who had circumflex artery involvement, the strain at rest, and of course on crouching, the stress. You see the reduction strain, which that was true in most of the cases, but these are some of the scattered examples we keep showing to tell you that regional strain could have value. As of now, it doesn't have value. The other thing which I said was there are two distinct domains which represent cardiac vulnerability beyond ejection fraction. So one is global longitudinal strain, and the other is extracellular volume by cardiac MR. So these will stand actually ahead of ejection fraction, along with ejection fraction, as important domains of cardiac vulnerability with regard to myocardial injury. GLS redefines criteria for disease classification. Let me just show you an example. Actually, this is a 36 years man with CKD. Look at the right side image. The ejection fraction is 52%. You might be happy with that. But look at the left side. The global longitudinal strain is just -7%. Look at the dichotomy between the two. That tells you that the patient has severe left ventricle systolic dysfunction. And you can't find out from the left ventricle. That is why strain runs ahead of strain vector. This longitudinal strain vector runs ahead of ejection fraction. And there lies the importance of strain. And that is what Dr. Burkule was showing you with regard to monitoring chemotherapy. The other thing is, of course, in valvular heart disease, and we are now understanding that asymptomatic valvular heart disease, especially aortic stenosis, the strain runs ahead of ejection fraction. Classic example, 62% ejection fraction in this patient. The global longitudinal strain is 10%. This patient has, the extracellular volume has expanded. This patient has fibrosis. He's a right candidate to undergo AVR before it is too late. But if you look at the 62% ejection fraction, you'll say, okay, I will do watchful waiting. That's not going to happen. Acute myocardial infarction, the regular kind of acute myocardial infarction with preserved LV function, those have a global longitudinal strain less than 14% are the guys who are going to develop heart failure. So you might say, I'm discharging a patient, or the patient is coming after 1 month, ejection fraction by echo, 55%. Should I bother? Of course you should bother. You should get a global longitudinal strain. If that is less than 14%, this patient is a high risk of developing heart failure in near future. The other thing is, even in general population ejection, the strain actually tells you about the risk. And this is actually a Copenhagen City Heart study of multivariate analysis showing as the global longitudinal strain falls, the composite of AMI, heart failure, and cardiovascular disease all go up. More in men than in women, and we don't understand the reason, but nevertheless, it is true that anybody who has a strain which is less than optimal, less than 20%, is at a risk of developing cardiovascular disease, heart failure, and acute myocardial infarction. So this incident heart failure in the Copenhagen City Heart study, multivariate analysis, incident heart failure increases as the global longitudinal strain falls. And this, as I said, is more true for women, men than for women. The other point, of course, is that you could use the global longitudinal strain to tell you about the extent of coronary artery disease. This is interesting. Actually, this data is from Egypt, but tells you as the number of coronary arteries involvement increases, the longitudinal strain falls actually. So in a way, If you want to find out somebody has effort angina, you don't want to do a coronary angiogram, you want to find out what is the sweat, just look at the global longitudinal strain. If the global longitudinal more like 10, 11%, you know this person has triple vessel disease or left main disease. Not necessarily, but it is puts you in the right ballpark. And the other thing is, of course, monitoring heart failure patients. Independent of heart failure, lower is the global longitudinal strain, higher is the mortality. Every 1% decrease in GLS increases mortality by relative 15%. Even in HFpEF, the global longitudinal strain has meaning. This is a TopCat echocardiography sub-study showing that those who had the global longitudinal strain less than the median, less than 15.8, had twice the risk compared to those who had more than 15.8%. Longitudinal strain quartiles, even in HFpEF, this is a paramount study where, of course, you know, the ARNI was tried. But you look at one thing, that the NT-proBNP level keeps rising as the longitudinal strain falls. So this longitudinal strain could be a poor man's NT-proBNP actually, to tell you what is happening to the NT-proBNP. Left atrial strain, I wouldn't take you through details. Dr. Anup Ray did talk a lot about that, but left atrial strain has independent prognostic value in patients with heart failure of both types, FRF and HFpEF. It also predicts filling pressure. So he did tell that in a case of indeterminate HFpEF is there or not, diastolic dysfunction there or not, look at the peak left atrial strain, less than 20%, this patient is in HFpEF and possibly has diastolic dysfunction, because there is a close correlation with global left atrial strain and pulmonary capillary wedge pressure, the inverse correlation. The similar way, of course, a much larger study, regardless of which type of heart failure you are talking of, there is a relationship between left ventricular end diastolic pressure and left atrial reservoir strain, which is pretty good. And there is a relationship with left atrial strain and NT-proBNP. And this is what actually Roberto Lang's group has suggested, that if the peak atrial longitudinal strain less than 20%, in indeterminate cases, you know that this patient has HFpEF. This patient has elevated filling pressures. However, in indeterminate cases, the peak atrial longitudinal strain is more than 20%, you might need other tests to confirm that the patient has HFpEF. Right ventricle function, of course, by free wall strain or RVGLS provides incremental value for prognosis, which is better than ejection fraction by CMR or even fractional area change, and of course, even by GLS or by MRI. So this is a heartening news that the RV function analysis is much better done by the acoustic spectral tracking, and it provides incremental value with regard to prognosis of heart failure patients. We, of course, can do a lot of pattern reading. This is a classic case of AL amyloidosis. You see the cherry on the top, and some people have quantified it, call it regional strain index, giving a very high sensitivity and specificity in diagnosing actually amyloidosis. Many of us may not agree to these figures. They may be biased, but nevertheless, it is a useful index of getting idea about cardiac amyloidosis. The valvular heart disease continues to be of interest. Asymptomatic primary mitral regurgitation. There is data from Cleveland showing as the global longitudinal strain falls, actually the prognosis becomes worse. And so there is a suggestion that you should operate before the mitral regurgitation global longitudinal strain falls below 20%. The same thing is true for aortic regurgitation. 19% is the cutoff in asymptomatic aortic regurgitation patient. It falls below 19%. You would be better off operating these patients early. And I did show you the example of aortic stenosis where different people have given different figures, but a figure of 15% is the right ballpark. If an asymptomatic aortic stenosis patient has a consistently the left ventricle global longitudinal less than 14.7, and asymptomatic with ejection fraction above 50%, good candidate to undergo AVR now before irreversible changes take place. So this is some threshold for poor prognosis for AR, AS, MR. Remember, these are just class 2 indications, class 2B in the recent the valvular heart disease guidelines of the European Society of Cardiology and also the American Heart Association. They're not class 1 guidelines, they're not class 2A guidelines, they're more like class 2B guidelines, indicating that more work needs to be done in this thing. So in clinical practice, a global strain parameter rather than a segmental strain value should be favored. That is first thing I want to give you a lesson. The preferred global strain parameter should be global longitudinal strain, and that is what is more robust, reproducible. Baseline and follow-up strain measurement need to be obtained using the same modality, same analysis system, same software version. Nitin actually emphasized on that point. Preferably same operator also, if I may say so. And that is the basic issue. And you need to actually keep that thing in mind. Major limitations of global longitudinal strain are methods, modality, and software version has to be the same. That is the major issue. Today you do it on a GE system, and after 6 months you do in a Philips system. Those are not comparable. Believe me, they are not comparable when only 15% change is to be taken in consideration. Our biggest difficulty is prospective randomized outcome data using global longitudinal strain ahead of ejection fraction are lacking. So value proposal remains intermediate. It's not a high value proposal. The typical example was Sukur study, which was monitoring chemotherapy, surveillance of chemotherapy using global longitudinal strain, and this study turned out negative. It did not provide incremental information over ejection fraction. This was a relatively small study, but it just goes on to say that with our enthusiasm for global longitudinal strain, we need to produce prospective, large, randomized outcome data before this becomes a part and parcel of our day-to-day practice. But it is useful. There's no doubt about it in day-to-day practice. And I want to give apologies to Alexander Pope when I say neither of the two are perfect, GLS or ejection fraction. But however, they suit each other admirably. I showed you the examples. So let me summarize, ladies and gentlemen. Strain imaging provides you objectivity, quantification, new information, more physiology, idea about synchrony, but large outcome data are lacking. Nevertheless, it is reproducible and robust compared to ejection fraction. Thank you very much.
Thank you, Dr. Mohan. As usual, great presentation. Before we close, just a quick comment. So as per my understanding, you have given more emphasis towards the global longitudinal strain rather than circumferential radial strain. So, but when you take the validity of the ventricular strain, be it or any chamber strain, for example, do you take into account the values of all strains or just longitudinal is alone?
No, the point is that we can measure strain in multiple different vectors. Question is, which of these strains runs ahead of known functional parameters? Is a global longitudinal strain which is running ahead of them. So we will use that.